Good evening, friends and scholars. We're excited to be together tonight, and we've got a lot to talk about as we're coming in. Tell us just on the chat while we're waiting a minute or two, what's the temperature where you are on this summer night? I can tell you it's getting warm in Florida. I'm not sure what the temperature is. I'll go look. Let's see.
86 where I'm at.
And
Probably
where
Ruskin, just
oh,
across the bay from you.
you're in Florida. Okay. So that must mean it's about 87 here. And about 85 where Laura is a few miles from you. Huh. How about in Las Vegas, Kim?
I think it was supposed to be like 108 today. I'm in the mountains outside of Vegas because that's too hot for me.
Yeah, that is hot. Sheesh.
Well, I'm glad to see a lot of familiar names on here. I know some people aren't showing their faces. Love for you to wave hi. Welcome all of you tonight as you're getting in. And we're going to be opening up for some Q&A from our symposium, showing some highlights. But we do want to just jump in and start with the case. And the reason I start with this case is I have to say that Dr. Gina and I have been getting labs back, and we just get so excited when we get such great outcomes. And I think people don't always understand how exciting that is when I think there's so many variables out of our control. And I hope some of you feel that way, right? You can do exceptional work at the chair, and then it's like you watch them walk out the door and you have no idea, are they going to actually do the things that we've asked them to do? And there's so many, I say, distractions, obviously, in life just to get somebody to brush their teeth, let alone what we work on some lifestyle changes, right? When we talk about diet and lifestyle, those can be even more challenging. So Dr. Pritchard, anything you want to add? Is I'm going to open up here with this case. I see that we have, nobody wants to tell us how hot it is or cold it is where they are. We're not.
One thing I'll say, Laura, in leading up to this case is that I do hope that everyone can begin to understand that you and I seeing labs and seeing carotid scans and seeing coronary scans and putting it all together, so to speak, we continue every week to be amazed at the systemic impact from even slight changes moving the right direction in the dental office, in the oral care for the patient. So you're exactly right. And this gets more and more refined, and we totally improve the oral microbiome in the dental office, improve sleep, and get oxygen scores up, and AHI's gone or zero or very, very low. The blood work and the coronary scores and the CIMT just continues to shock us, honestly, and blow our mind. We continue to be reinforced every day that the healthcare that is needed in America now is all of us speaking the same language, whether you're whichever side of the aisle you're on, as Dr. Wilkerson says.
Mm-hmm.
And I think that is our big mission, right? Just empowering all of our dental medical colleagues really to come together to provide a better care. Can we help our patients live longer, healthier? And I think that what we're doing here in IDM as Scholar Society is actually showing just what's possible. That's what we want to empower you with, is that you can go out there and do these same things. There's nothing special about what we're doing, really. I want to say that from the bottom of my heart. We want to share, we want to give, so that everybody can be going out there and seeing the same thing. And that's why this case is so cool, because honestly, it's not like a home run out of the park first thing. Well, I'm going to take that back. Dr. Gina, a home run for you, maybe. We can see that some life altering, and the patient is eventually going to share her before and after. So you're going to start seeing that more with us, as each time we come in, we do want to share cases. So I'm going to share my screen here with all of us. So we're going to talk about this, and Dr. Fisher, I'm going to have you actually lead us off about this case. I would like to tell a little bit of the backstory of how I took the phone call from this patient. She's a lovely patient. She was younger than me. She called into the Prevent Clinic and I triaged her like, great, do the little background. We don't just let anyone get to Dr. Gina right out of the gate. And I just like, there's just some people, your patients, you just feel their heart through the phone. And she just like struck to the core of my heart. Some of her health history that she was sharing with me, and that she couldn't get any help. And so when we saw her, and you'll see on that medical history, she's 45 now. She was 43 when she came to us. And I begged you to take her as a patient. So tell them a little background about that.
Well, we've gotten better and better. Very seldom do we say to a patient, I don't really think that our practice is a fit for you. Very seldom. But we do have radar up in that there are some individuals that give us some wording at the beginning that we're like, we aren't a great fit for them. Because in other words, someone that is a perfect fit for our practice has had a heart attack and calls the office and says, I can't ever let that happen again, or I'll lose my job, or, what will my family do? Or I had a stroke, and if I have another one, I might not even be able to talk or walk, or I'm getting to be possibly about the same age as, say, my father or my mother. They have a significant family history, or a test result that they and their doctor are worried about. Like, they have a motivation to do some things to make sure that they don't have a future filled with heart attack, stroke, diabetes, or dementia. So that's a perfect fit for our practice. We love it when we get younger people that say, I just don't want to have any kind of health problems in the future. I'm very proactive about my health. So it's exciting because we are seeing younger and younger patients. However, this patient, young at 43, I wasn't hearing any of those things. And she wanted to lose weight. And honestly, looking back, I realize now that I was still in the mindset of how we're all brainwashed to categorize people. In other words, where I'm going with that is, we all know now that we're looking at sleep, and we're looking at airway, and looking at oxygen levels, and how much deep sleep and REM sleep is someone getting. We know that anybody has a possible problem in that area can come in looking like ADHD, or be on multiple psych meds for depression and anxiety. They can have a lot of issues, right? And we now know to start with sleep, and start with airway, and start with oxygenation. So we first saw her in 2022. And while I appreciated at the time, I was just hearing and seeing this is going to be difficult to get this young, beautiful, nice, kind female patient, potential patient, off this laundry list of depression, anxiety, muscle relaxant, meds to go to sleep, meds to wake up, meds to make it through the day. She had polypharmacy, huge for a person any age, but much less at age 40. That was concerning to me. Secondly, her main goal was weight loss. If she could just lose weight, because I'm sure Laura will tell you the story. She wants to call her the bodybuilder's wife, the bodybuilder's fat wife. We won't say that to
Not anymore. She's 107 pounds right now. So
exactly.
let's put that in perspective. But when she came, I was like, oh, she's like the fat bodybuilder's wife. Like, they do not look like they go together. I felt so bad for her.
Yeah. Yeah. Because he was consistent working out in the gym all the time. Anyway, so I had just some red flags. So I said, let's meet with them. Anyway, to make a long story short, Laura convinced me, and we said, okay, let's see this patient. Because, the other thing is, heart attack, stroke, diabetes, and dementia prevention, not even on her radar. She wanted to lose weight and look great for her hot husband, and she wasn't functioning well in life. She was depressed, she was anxious, so you can see why I thought this might not be a fit. But Laura saw something that I didn't see, and when we got our first set of labs, I'm like, oh, this woman is incredibly sick, and has no clue. It's not even of concern to her.
So all of you that were at our symposium, I hope some like red flags are just going off, that I'm going to say just a few years ago, we kind of knew, but we weren't, like Dr. Gina was saying, like making that number one. But in the back of my mind, I kept saying, what if she has such an oral problem? What if she's already diabetic? What if she already has inflammation going on? And what if everybody is missing the root causes? So those are the things I want you to just start thinking about. That you're at the symposium, you heard all these fabulous speakers, like, right, what were some of those connections if you were taking this intake call or listening to a patient that was in your chair? What would be kind of going off in your mind? And so these were her before labs. So Dr.
Yeah, and
Hidra,
so
walk us through. Yeah, what were you seeing?
well, you all have heard us talk about, and many of you are very familiar with the inflammatory panel. And so, one, when myeloperoxidase is elevated or plaque 2 is elevated, which in her case, both of them were, as you can see, elevated, we know there's a problem in the arterial system somewhere. We don't know if it's in the heart artery, in the brain artery, but in the wall of a blood vessel, giving life-saving oxygen and nourishment to every cell in the body. There's plaque that's vulnerable somewhere. There's inflammation and oxidation occurring in the wall of the artery, no doubt about it, with these first two inflammatory markers elevated. Then the way we tell patients is C-reactive protein also is a marker of inflammation, but can be a chronic problem. It's not specific for the arterial wall. The other thing I'll say before I leave those three is that when myeloperoxidase is elevated, we all know that to talk to our dental colleagues, those of us that are on the medical side of the aisle, non-dental, to talk to our dental colleagues, because it can oftentimes be an oral health issue in particular driving that myeloperoxidase. And it can be a significant root cause that's on both of our care plans that we've got to tackle together, that being insulin resistance or prediabetes. So either way, it's step one, elevation in this first inflammatory marker right there. We don't need to look any further. Dental and non-dental teams have to work together in order to solve the case, if you will, and make this person move towards health. Then when you go down to ADMA, remember asymmetric dimethylarginine, greater than 100, just bombs start going off. Well, we have to evaluate sleep in this individual because we know that nitric oxide pathways are impaired when ADMA is elevated above 100. We've talked about that in our courses, so I won't go into detail about that now. But everybody gets a sleep evaluation and a 30-day sleep image ring or a watch pad or some form of evaluation of not only quality and quantity of sleep, but of their oxygen status, airway status, a cone beam CT, etc. Anyway, but when ADMA is elevated, of course, we know we need it. And then lastly, F2 isoprostane is low. I won't even elaborate on that. I will say when we go into cholesterol profile, that the more labs that Laura and I see on the, and we see all the dental records and we see the non-dental medical records, this lipid panel really should just be moved down to the bottom of the conversation. It's not to be ignored, but we see this come into line when everything else is addressed. So to just see somebody, whether they're 43 or 93, and see a cholesterol profile like this and slap them on a statin has not dropped the heart attack rate in decades. Whenever statins first started even coming out, we have not seen the heart attack rate drop. So that's all I'll say about that. Yeah, it's alarming. There's a lot of red, but Laura and I talk about diet and lifestyle, and maybe we'll add a medication later. Anything else you want to say before we go to the next page, Laura?
I just want everyone to not miss those top really three that you talked about. So myeloperoxidase, I'm thinking, oh my gosh, does she have an abscess somewhere? I need a cone beam read. Then I see her plaque 2. I'm like, she probably has perio, right? What do I need to be able to evaluate that? And then her ADMA, like Dr. Gina said, obviously there is a desaturation, even if she doesn't have obstructive sleep apnea. Like, why does she have this inverse relation of nitric oxide going on? Is she not nasal breathing? What's actually happening? And we do have some more initial labs. So let's just kind of briefly cover a couple of those, just because she does have some, even if you just go through, if you're looking on the right for me, it's like low, 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 low on some of those things. But just talk about maybe that APOB. We hear a lot about that, Dr. Pritchard.
Yeah, so ApoB is of the LDL lipoprotein family, if you will. ApoB is the particle that's the smaller, denser, stickier, more problematic, more likely to become inflamed and involved in the oxidation process. So to stir up trouble, if you will, in the wall of the artery. However, I would love for all of us to just get rid of those words, HDL, good cholesterol, and LDL, bad cholesterol. That's not really true. LDL initially can be helpful in the process. It's when it becomes oxidized. The reason I'm saying all that is if you're going to look at anything on the cholesterol profile, it's look at the triglycerides. I mean, look at all of it, but the triglycerides can be incredibly important and help us understand about this patient's dietary, lifestyle habits, and important in looking how close are they to diabetes. And then when we look at the lipoprotein, apolipoprotein B, we do want that to come down. And we always check, and I say always, we didn't have it on this individual because I guess we weren't always doing it in 2022, but now we always get oxidized LDL. Debate about whether that's the best way to determine if the amount of apolipoprotein B that you have is problematic or not, but it's one way we can look at it. So all of that being said, apolipoprotein B is one thing we expect to come down when we're treating dentally and non-dentally with a collaborative care plan. But the next metabolic category, and then we'll look at compare it with a couple of labs over on the left. Obviously, her glucose is 100, and a lot of people would go, no big deal. Is it 106 or 100? I can't really, it's so small. A lot of people would kind of snooze at that and say, well, it's nowhere near 120. You got to have 2 fasting blood sugars of 120 or greater to have diabetes. But all of us in this oral systemic movement want to be more detailed than that, because a fasting blood sugar under 90, under 80 is healthier. And all experts in the field of insulin resistance and prediabetes and would have studies to support the fact that a fasting blood sugar of 100 on a consistent basis is still not ideal insulin and glucose communication. Here you've got a hemoglobin, an insulin level of 10. I've got to make this higher. Is that 10?
10.
Yeah. Is too high. First goal for our patients is to get their fasting insulin under 10. Hemoglobin A1C wouldn't raise an eyebrow, right? At 5.4, estimated average glucose is 108. Most people would go, you're fine. Remember what we've learned for many, many years. The hemoglobin A1C that's normal, okay, take it in context of all the other labs. If it's abnormal, if it's 5.8, 5.96, then it is significant. If it's normal, all that tells you is your average isn't bad, but that doesn't mean you don't have spikes up to 200 or higher, and then you've got lows. So we have to make sure we don't reassure our patients simply based on a hemoglobin A1C. We've got a fasting glucose that catches my eye. It's a little higher than we'd want. We know she's at least insulin resistant, especially with the fasting insulin of 10. Anything else you want to say about that before I go to liver enzymes, Laura?
I do the homocysteine there at 11. And I just, that's one of the things we point out all the time is like a supplement thing. We talk about lifestyle and diet. And to me, right here with our dental community, especially, it's like these are things to be talking about, looking at, because, right, it's not just metabolic health. We know there's a direct bi-directional relationship here between, I'm going to say, diabetes and periodontal disease. But this was a huge driver in her case. And so it's like you said, most people would have totally told this patient she's absolutely okay. And there was definitely red flags here.
Yeah, absolutely. Her nutrient status is nowhere near what it needs to be based on that. And I don't think we didn't put liver enzymes on here, so never mind. I'll come back to that later. So we did optimize her B12 status, her B complex status, her coenzyme Q10 there was fine. You want that above 1.5. Her vitamin D, incredibly low. That's important for oral and medical, right? We all know that vitamin D level needs to be, I think all of us would agree, above 60. There are still a few people that are just shooting above 40, which is too low, in my opinion. There's a lot of studies to support the fact that a vitamin D consistently above 60, when all other variables were factored out, that those individuals have very little incidence of cancer. So we definitely want to keep the vitamin D level above 60. In our office, we shoot for consistently above 80. Then we have what I say some wiggle room. It's nowhere near toxic at all. What the toxicity of vitamin D is talked about way too much. Yes, you can get toxic. It's a fat soluble vitamin, but we're checking labs frequently. It just doesn't happen. When they go high, we decrease the dose. Anyway, vitamin D, we started on vitamin D3 with K2, a large dose because it takes forever to get it above 80 if you start out at 34, if you start at 5,000 or even 10,000 IUs a day. So we usually start at least 10, sometimes 20,000 IUs a day. And then we say we can always cut back on the dose when we look again in 12 weeks. And then her omega-3 fatty acid status was not awful, but the 3 omega-3s that are healthy are the EPA, DPA, and DHA. And so the EPA and DPA were fine, DHA slightly low. And then she had some omega-6s, omega-3 that was low, and linoleic acid that was high. So it's kind of all over the place. So we really just did not start her on omega-3 supplements, but we talked to her about she's getting some omega-3s from the food she's eating, which foods to focus on to continue to get more omega-3s, and then get rid of everything in a box, all of the processed foods that could be contributing to the omega-6s. And let's just see where we stand when we check again next time. But as Laura was saying, that homocysteine that tells us her detoxification pathways are impaired will improve if we get her vitamin B complex and B12 status where it needs to be. So 966 for a vitamin B12 is too low. It's a water-soluble vitamin, and it needs to consistently be above 1,500. And I don't care if it comes back greater than 2,000. It'll show up high based on this Quest reference range or Cleveland Heart Lab reference range, but it's a water-soluble vitamin. You'll just get rid of it if you're taking too much of it. And until we see the homocysteine continually come down below 9 and stay there, we'll keep going up on the B12 dose.
So takeaway dentally is I've got some bad cholesterol. We know pathogens will increase that, right, in the blood from their endotoxin. I can see it here. I also am constantly looking for that insulin resistance because that can be a root cause driver too for these pathogens increasing. And then, of course, we really need to get grounded in our K2 and D3. We're seeing all kinds of great research come out about bone health in the mouth. This is related to our implants, to our surgeries, and to our periodontal disease. So we have to be grounded in some of these things and just understanding, right, where do we step in? How can we help our patients as we read the literature and then apply it to what's going on with the patient? So this was supposed to be her first one. She did come in at 43. We did ask her dental history. I have to tell you, she had the same dentist her whole entire life, loves her dentist, and adamant about, I have nothing dentally wrong with me. Absolutely nothing. The only thing that she would say is that she had some TMJ issues, had a splint a couple times, but that was it. Other than that, like, adamant that I'm barking down the wrong tree. So we've all been there. I want to let you know. That's why I wanted to share this case, because you're going to see how it starts to unfold. And so sometimes we have to take a deep breath, right? As a provider, because again, what was her primary goals? And I will tell you, her mental health really trumped everything. That was one of my big root causes and why I pushed so hard as a provider and as a care coordinator on Dr. Pritchard's team, is that I knew we could help her in some other ways that then we could eventually get there. And I think we have to be mindful of that. As much as I want to jump in on all the dental things, you know, the hand was here and we acknowledge that. But I'm going to show you where her first test was. Oh, and sorry, her name is on there, but I do want you to see she had FN and TF going into it. And so we weren't like, okay, she doesn't have all the drivers. Let's take a deep breath. Is it airway? Where is it coming from? So now let's talk about where we are today. We just did these in March. We're going to fast forward here. And you can see on the far right, if you look at these dates, you can look at 2023, 2023. This was one of her better labs. And overall, Dr. Gina, right, she's getting better. We just keep making progress. But my dental colleagues, I want you to see something that is consistent here. What am I pointing out? Anybody know in the chat? What am I pointing to on this PLA2? What keeps coming up to me? Anybody respond in the chat? Come on, who's brave?
Periodontal disease.
Yes, thank you, Dr. Harkness. Yes, plaque 2 is just consistently in red. We can see the myeloperoxidase got better. We can see she's fluctuating a little bit with ADMA, but that perio is just like sitting there to me, just consistently high, right? And so awesome job there. And that's really what we were talking about in the symposium. It's like being able to take some of these things, understanding that, right, if somebody did share their blood work or what's going on, what would be some of the flags to see? So I'm going to keep moving because we want to get to Q&A today and talk about symposium, but we want to share these cases. Dr. Gina, what do you want to tell us how you're getting rid of? I mean, she was even a little better. She went on a cruise. So I do have to tell everybody this little, some more reds and yellows there. If you go back just previously in December, which is a hard month to have good labs, I say, with holidays, but she was making a lot better progress.
Yeah, and I would say over on the right, which is the older lab, you can see her labs from baseline in 2022 had gotten better. If we look at the triglycerides, like I was talking about, triglycerides were 76 October of 23, December of 23, triglycerides were 59, which is excellent, far better than what we saw at baseline. And then she went on the cruise. And so you can see how this individual and all of us that lead any kind of what's a typical standard American diet, we're not sleeping well, we're really not moving our bodies like we should. We're just on the verge of getting very sick again because her triglycerides, just because she went on the cruise and before we went over these labs, she said, I went on a cruise and I had all the alcohol I wanted and I had desserts when I wanted them. And it's not the way I've been eating when I was at home because, I've been doing so much better at home. And you can see how our triglycerides went up to 106, of course, as did her total cholesterol. And her LDL isn't good as well. And we saw the same thing on her metabolic numbers. Her fasting glucose was higher. Her liver enzymes were creeping up. So you can really get some clues as to what kind of changes the patient is making at home with this blood work, and or do we have everything covered that we need to have covered with the root causes in both the medical office and in the dental office. When we just see the labs moving one way or the other, you can kind of, Laura tells the patients, we have truth serum on you.
Well, and I just want to highlight here, look at that myeloperoxidase, right? She was good, then just a little creep up. We talked about plaque 2, but look at her CRP. Remember, we talked about that? She started at 1.6. Look at this. Just really helping her globally with her inflammation, and that ADMA keeps fluctuating. You can see back and forth, back and forth. And so here's where the oxidized LDL becomes important, right, Dr. Gina? Because it really lets us know. So you can see she's been making good progress even when she was bad, when you talk about in relations to the lipids. So tell us about that.
Yeah, so LDL in and of itself isn't problematic in the beginning, but it's when it is a part of that inflammatory process that begins to occur in the artery wall, and at first is helpful, but then it can become oxidized and sort of go, I say, to the dark side, where it's not as helpful anymore, and the immune system is actually losing the war. So apolipoprotein B, the LDL particle, and the oxidization of the ApoB or the LDL incredibly important. So with this person, with her oxidized LDL being 55, and we had known it had been higher earlier, when you go down and look at her LDL, that hadn't changed that much, and her apolipoprotein B that hadn't changed that much, I was reassured when her oxidized LDL is low. Again, not the perfect test. There are far better tests coming out very soon for us to try to understand, are we winning the war or not in terms of the lipid panel and combining that with inflammation and metabolic markers. But that did give me some reassurance that even as she had thrown caution to the wind on the cruise, at least her LDL wasn't oxidized.
Okay, so we have to say for us, you might be like, really? This is a huge case? Yes, because she is off. I don't even know how many medications, but mentally, can you just speak about her mental health? She's completely a different person. She did do peptides, we did lifestyle, we did diet, we slowly weaning off medications and looking at hormones and looking at diet and supplementation. And her weight, what did she lose? Over 55 pounds? I think we might be
Yes.
at 60
Yeah.
now.
Right.
Week. But tell us a little bit about that, because her just outlook on life, if you would have talked to the person who called versus the person who we're going to get a testimony from her for who she is today, you'd be like, one, they don't even look like the same person. Two, just a totally different outlook.
Totally different outlook, totally different person. Like, she had more negative things to say than positive when we first met her, and was obviously battling depression and then anxiety, and we just, so much of our conversation revolved around all of that. And now she has such a bright smile, and she's always so happy to talk to us, and she's always telling us about a positive affirmation, a new plaque she's put in her home, or a pillow that says home sweet home, because she's so happy. And they have such a happy home life now, her and her husband. It's like night and day, totally different. And we are whittling away at this polypharmacy, all these medications that she's on. But it would have been totally inappropriate for us to have started there, because we first had to get her metabolically healthy, orally healthy. We're still working on sleep with her. These are long range projects. Some things you can get quick wins, but it takes a few years in some cases. But either way, we saw a dramatic difference in that first few months, and definitely that first year. And she just continues to be a happier, brighter person. She wasn't even working when we first met her, which is fine. Not that everybody has to work, but she
No,
had
she
to
was
get out.
in bed. Yes,
Yeah.
she came to our first consult, her and her husband in their bed. That's why Dr. Gina was too, like, no go. Like, they're sitting in their clothes. She wouldn't even get out of bed to go to work. She wouldn't get out of bed to have the consult. This is now a woman who's full functioning, running her husband's business, helping him. Like, you would say maybe they were related, and that's like her older sister that you originally met when she was actually younger. She looks younger now and acts younger and so much more active. So that's the emotional piece, I guess I want to always say, because for me, as much as I want to jump in there dentally, and we're going to go there now, because now she's more open and more willing. Because imagine me telling her, you have to go to the dentist and do all these things, when she can't even get out of bed to like make breakfast or to help her husband at work, right? I think we always have to keep those things in perspective. So
Yeah, and
had to
before you go to
rethink-
dental, I just want to say this was amidst many crises that occurred in her family. She's mother of two boys, and both extended family and within her own family. And there was a lot of crises and a lot of drama, a lot going on. And so for her to make this turnaround, despite things continuing from time to time to just flare up and get worse, and still get off some of these psychiatric meds and still improve her outlook on life. Just amazing. Okay, so go ahead.
Well, and I think that's important. You know, we're not really showing you the whole in depth of hormones and peptides and thyroid, but there's so much. And that's why I want to say there's so many variables to everybody's story. But there are some common things that we do see. And that's what I want to say to all you. That's what hit me when you're like, why didn't you just say, okay, Dr. Pritchard, you know, you don't think this is a good candidate? Because I saw myself in that person. And I think when somebody makes you stop and think, all I could think of is, I can't give up on this person, because where is she going to be 2 years from now? And for me to see where she is now in 2 years, that's the hope. That's right. That's why we're all in healthcare is, hey, if we can at least try, because I told her out of the gate, you know, we might not make a difference, but if you're willing to try, we're willing to try. So now I have to have this revisit conversation for her to go to the dentist. And I asked her if I can send her somewhere else to another colleague just to get a reevaluation. Let's get a new saliva test, testing her husband. We know those pathogens are there. We believe there's still an airway issue. And so here is now her current before, and you can look at the dates here. Finally got this on her. in the beginning here of 2024. And she does have those red complex pathogens still at very high levels. We even have high FN, we have high FA, which is the more virulent type. So I am worried about, right, crossing the wall of the artery. These are very permeable and they can really pull the red complex in. I'm sitting here and look at these strep mutans. All I could think about is, does she have cavities? She's told me she hasn't had a cavity in like 10 years. And I'm like, I don't think that's possible. How do you have that high level of strep mutans and not have a cavity and not that many good sanguinis? And then look, we even have this yeast going on. And so when a yeast is present, we know it can shield the red complex. And that's the concern, is that her immunity isn't able to recognize that she has a bacterial infection. So sometimes their signs and symptoms won't be as exacerbated or as bad. Like she may not have bleeding in the sink. She may just say, oh, my cleanings are okay. They just keep telling me what she was, brush and floss better. But we know that now this is a much more severe infection. It can exacerbate what I say, like underneath, kind of like think about an iceberg, right? We're just seeing a little tip here, but the yeast is allowing that to brew and grow. And so our decisions now, like, should we use an antibiotic or shouldn't we? Well, I'm going to look at that host response. Yes, I have yeast involved. So it's hijacking my immunity. And then, oh my gosh, we also have a viral load. Her body is trying to fight that off. So this host, her body is struggling, even though we've gotten things a lot better. I know that she's still struggling with this bacterial infection. So here's the really cool part. I send her to our colleague. I don't believe our colleague's on tonight. Can you see if she's here? I don't believe she is, but we sent her to one of our fellow hygienists locally in Texas. And I beg her to run my protocol, talk to her about it and say, right, can we get really good care? And I'm going to share with you, it's Karen Davis, because I think she should get credit for these cases that we're doing. And she called me and she's like, this woman is eating sugar. She has 14, like she might have more now, like 14 cavities. She has periodontal disease. Like, and I'm like, thank you. Because literally I thought I was going crazy looking at these tests because her previous dentist is telling me she's fine. She doesn't have periodontal disease. She doesn't have any cavities. There's a few things that I'm watching. So again, sometimes getting that second opinion for us was really important, that we could have fresh eyes who kind of understand the oral systemic connection. And what's interesting is we've never had this severe of a case before where somebody's telling us there's nothing and somebody else telling us we have a lot of work to do. But regardless, she got into the right hands. And I want to show you why we picked this case today is I literally just downloaded this. She received this case. Look at, we just got this back. This was June 3rd. And look where she's at. We have completely shut down the red complex. We still have a little bit of FA, but we know it's in the green. We're going to keep working on that. It's actually what we commented to her. In fact, I did a group text with Dr. Gina today. It's like, woohoo, look where we are. Keep doing what you're doing, right? Look at, we shut down these strep mutans, completely gone. Obviously with the help of my dental colleague, because I couldn't do the fillings myself. I couldn't do the periodontal treatment myself. But look what's going on here. Just fantastic. The yeast is completely now in check. And that's something I want to tell a lot of people. I don't tend to go right after the yeast because I want you to think about yeast infections. It's when the bacteria is out of balance, the yeast will overgrow. So many times if we focus on that red complex and get the bacteria in check, the yeast will follow. They will come back in balance. So that's one of my big tips and takeaway, because some people do the reverse. They kind of focus on yeast. And I want you to think about all the females in your life. Why do they get a yeast infection? It's because their bacteria is out of balance. Can I create health and get the bacteria in balance with probiotics and healthy products there that we can make that work? Now, is our work done? No, we have to sustain this. And I'm going to be throwing this right back at Dr. Gina because we still have cytomegalovirus showing up, which is her immunity. And we know then, okay, we're going to be going back to the supplements, right? Dr. Gina will be looking at her zinc, her B vitamins again. We know sometimes she struggles with some of that. In fact, that was my worry on this case, is she had been texting me like, We do a GI shake to help rebuild their GI. She's like, I just can't do it. I can't take it. It doesn't taste good, right? And so you worry about all those patient variables. But the minimum that she was doing, we see really helped.
One thing, Laura, I want to probably everyone's thought it, but like this is year what, 3, almost 4 that we've been working with this individual. And so any of us that are still in the mindset of find the problem, give it a diagnosis and treat it, and goodbye, we'll see you next year. That really isn't what we're talking about. This person would be no better, even if the person had just filled the cavities or identified that there was 14 cavities back then, or giving her a medication for the cholesterol and sent her on her way. We're really talking about a transformation, moving our patients towards creating better health, away from multiple disease processes that were going on. So my whole point about that is you can see that, yeah, we were checking her saliva. We were not able to move her dentally. She just wanted to lose weight. We were not able to create a strong enough connection that part of your problem with losing weight may be something going on in your mouth, but she just couldn't go there. And in the beginning, it took us 2+ years to actually get her to move on the oral health issue and finally say, okay, I'm not leaving this dentist that I've known for years and loves, but I'll go to your specialist and see what they have to say. And now she's a believer, obviously, because she's seeing what we've been talking about. But I just wanted to point out the fact that this is being an advocate for your patient for the long haul. It's not a name it, give it a procedure or a pill and move on. This is a years-long process with patients to actually improve their health, because we know we're saving this 43, 45-year-old female from heart attack, strokes, diabetes, and dementia in the future. She was knocking on the door of diabetes when we first saw her, and now her numbers are looking so much better. That's just one example. Anyway, I wanted to make that point, and then I wanted to make the point for those of you who perhaps, even after we got her to Karen, to our dental colleague, and got her on appropriate diagnoses and appropriate treatment, she still was kicking and screaming, right? Like you say, she didn't like the GI protocol, and she had set that aside. And yet we're giving her antibiotics. We thought, we have to heal the gut. As soon as you're off these antibiotics, you got to go back to it. And almost everything, like, oh, but all of this money, and really don't want to spend the money right now. And when our mind, it's like, we've been trying to get you to understand there was some money involved that you needed 2 years ago. Now that it finally year 3, you're willing to do it. We're not recommending it just because it's a frivolous thing. That's all. We have to have excellent communication skills with ourselves and our whole team in order to be patient, but at the same time, nudge the patient along wherever they are in the process.
Really where the collaboration took place. I was on the phone quite a bit with our colleague talking about it, because she was giving me insight from conversations she was having about how she went back on sugar, what her daily diet was that I thought we had under control. And my insider colleagues telling me, wow, she's actually doing this. And I was doing the flip side. When she's coming to talk to us, Dr. Jean and I were really supporting, we need to get the fillings all taken care of, right? We need to get the periodontal treatment completed. Then we'll work on the airway. And so we were constantly back and forth, kind of reinforcing. And I think that's the true power, because she could have walked out of there and said, I'm not getting any of this dental work done, right? Or I don't want to do the fillings, or I don't want to do this. And so that's where collaboration becomes important. I really want to commend you, Dr. Gina, because you stepped in and said, I need you to get that done. That could be a big driver in what's going on here. And I think our patients need to hear that it's not just a cavity, or it's not just that you're losing bone in your jaw. There's a much bigger issue. And that is very powerful when you have both sides helping each other. So it really helped me, because then my dental colleague, we were sharing what the GI protocol, like what her lifestyle diet should be, so that when she was in there each time, she could be reinforcing that same message, like, how are you doing with that? Well, let's keep that going. And that's very powerful when the team's saying the same thing. So I do want to open it up to questions. We do have another case, but I just want to share with you that one of our big missions here is really just revolutionizing dentistry to reconnect medicine and dentistry together with these root cause diagnosis. They really help us form this path for healthier patients. We know that she's going to continue to get healthier and healthier. And I say on so many levels, not just what we can see in blood work or what we can see in a saliva test, but really just having a conversation with this individual has been really, I'm going to say emotional and life-changing for both of us, everyone on our team. So let's open it to questions. Want to talk about the symposium? If you want to go into another case that we share symposium, we have that ready as well. But I'd like all of you, takeaways, questions, let's open that up.
Either
Michelle?
post them in the chat or raise your hand or just speak up. Who wants to talk?
Okay, this is for Gina. This is Isaac.
Hi,
Hi. If you talk to your dental colleague about MPO in a particular patient, she sees or he sees the dentist, MPO is not coming from the mouth. Where do you go at that point?
Insulin resistance. That's the next place I go. Metabolic health. This person is likely not perfectly healthy from a standpoint of insulin and glucose communication. They're either insulin resistant, pre-diabetic, or I say knocking on the door of diabetes. Not always the case, but that's where I go next.
Okay.
Okay, great question. Great question.
Laura, do you know what the protocol was that Karen Davis used to get those numbers so much improved?
Dr. G, you want to answer that? I think I'll answer. I actually have it. I can show you because I had to have a conversation with her because I asked her not to use her protocol, to use our protocol. And that's why we're very hesitant sometimes in collaborating, because we do want a certain protocol run from the Prevent Clinic. And so I can run through that because that is on our case. Most people do want to know what those products or what that was. But Dr. Gino, that was our pre-conversation with our colleague is, hey, we're going to be sending patients. We had to get the buy-in, correct, Dr. Gina? It was like, hey, will you run this with us?
Right, absolutely. And Karen, we had probably what, an hour and a half conversation with Karen, and she's lovely, as you all know. And she's like, I want to learn, and this isn't what I would do. And so send me the data and let's talk about it, because I'm open, because it's, a mutual patient. We all want to be successful. So she read the articles and we met again, and she's like, okay, well, what have I got to lose by trying it with the protocol that Laura has suggested dentally, and reinforcing what I was suggesting from a medical standpoint. So we were all saying the same thing. So, God bless Karen. I wish she were on here, because she just said, I'll do it. Let's do it. We actually had 3 mutual patients right there together at the same time. So she said, if I was ever going to try it, I'm going to try it now on these 3 patients. And
So tell us what you did, Laura, or she did.
Sure. I think the first thing is that we do prep our patients GI wise. I know it's hard sometimes on the dental side to do that, but I think it's always a good idea if you can, if we're going to put somebody on antibiotics, to have that conversation ahead of time. Like, I want you on probiotics, and Dr. Gina, you can speak to that. We do Dr. Gina's GI Gems. We do her shake anywhere from 2 to 4 weeks, depending on the patient's GI or situation, in response to antibiotics. And then we start the treatment, and we take them off everything during the 14 days of antibiotics. Please make a note of that. It's one of my secrets, because when we use antibiotics such as metronidazole, remember that your metals, so like your zinc, your iron, we have some patients who need iron, right? Your magnesium, those things are going to bind to metronidazole, and they're going to take them out of the GI tract. Basically, they're going in the toilet. So we're putting in the antibiotic, and these things are taking it right out. It's not being readily absorbed. So if you've ever used an antibiotic and said it didn't work, I would say a lot of times, because some of these patients are heavily supplementating, or they're on a GI, such as our GI shake, that also has so many great things in it, but they do bind to antibiotics. So we have to be mindful of that, understand how our medications do work together. And so I just want to talk about that. So we always want to do that pre-saliva test. You saw 2 of them there, and you could see we started with that. What are we working with? Because I'm always asking, do we even need an do they even have like red complex or anything that I have to worry about vascularly? So I'll be honest, in our practice, if you have red complex and at high levels, we're going to go tend towards that antibiotic route, right? Then we're looking at, is there candida, so yeast, or a virus? That's really going to let us know how aggressive we need to be, how long. And so we're really going to err on her, especially those 14 days, because we need to be pretty aggressive. Now, I'm lucky that Karen had all these things that I was asking her to do. I will say she does not have ozone, so please cross that out. She did just irrigate for me. So she does have that laser. She was able to get in there and laser. You know, she's one of the first ones who've ever been certified in GBT with her airflow. So we went through that. What does that look like? And we really talk about layering like a cake in the chair, meaning, right, we're going to do that laser, you know, biofilm reduction, because we know that the red complex is in that epithelium. We know the orange is completely too in the tissue. The red complex is going to move on into bone and in the bloodstream, especially once you hit those 1,000 levels. And then a tongue prophy, like she's like, what is that? Some people have never done that. We have to remember that the tongue harbors so much bacteria, even if they're anaerobes. Remember, that's the maturation. So we want to get a clean slate in there. You know, it's just not, I say, drive-by cleanings, whatever you want to say, or laser or GBT, because our saliva, it's a constant circular flow. It's constant movement. When somebody says, oh, I'm just going to go in a pocket and test that, well, the bacteria just aren't sitting in one little area like, come get me. We have to remember that movement. And so I want you to understand that concept. That's why we want to spend time in the entire mouth. And then she went through her ultrasonics. She did 3 tips for me, went through that, took her time. Obviously, this patient was numb. And then any hand instrumentation. And then we back out minimally. We're going to back out. So we're just going to repeat now these in the opposite direction. So we repeated at least 1 tip with that ultrasonic. We're going to do, I call that a biofilm wash, flushing out. We're constantly want the bubbles to be breaking up any cell wall. Because what is our job in there? Are we really killing these bacteria? Are we killing the red complex? Does anyone know that answer? I see a couple people shaking. Yeah, no. But what are, yeah, we're just disrupting, and the yeast has created what I call a stronger roof, an even stronger cell wall. They shield that complex. So if you think about it like a bullseye, the yeast has this really heavy outer ring protecting all these red complex that are like in that bullseye. Think about the bullseye as being that red core. And so we want to use all the acoustics and everything we can, our hand instrumentation, whatever you have, to break up that outer, what I call complex, that wall, that extracellular matrix. And the extracellular matrix is not what lives on the tooth. It actually lives in the epithelium. So that's really was a lot of our conversation of when we're in there. What are we thinking about? This is non-surgical. What are we focusing on? Right? That's what we want the focus to be. So we want to slow down. Of course, she's going to remove calculus. Of course, she's going to, you know, get rid of stain and all those things and root plane. But it was really a mindset going in. Like she said, okay, I'm really thinking about this differently. And then irrigated, she just irrigated the chair. And then we did a varnish on there just so she wasn't sensitive. I do have to give a little side note to Karen. I hope she has pictures and she'll share this live with us one time. I'll have her come and bring the case once we have everything completed with the new blood work. But she told me the dentist had told our patient that the spot on her lower tooth where it was stained, well, Karen said it was stained. The patient said it was her tooth. And the dentist told her that it could never be removed. And so she removed it and took a before and after and like had the patient see there. So I think all those things were very enlightening for this patient from a dental education point, like what she thought maybe were problems weren't and what were are and vice versa. But we had a few little giggles in between there. So we put her on the combination here, and we actually adjusted this, Dr. Gina, didn't we? We did. Do you want to share it too? So because this patient with her compliance, and this is a decision a lot of you guys can make, A lot of the traditional way, amoxicillin, 500 milligrams, right? And the metronidazole, 500 milligrams for 14 days. But because of her compliance, remember I told you she always like, I can't do this. I don't want to do that, blah, blah, blah. I always take personality into consideration. And so discussed it with Dr. Gina and with Karen, and we decided to go with Augmentin 875 because that was BID twice a day, along with the metronidazole and BID twice a day. And that could be so much easier for her to take that I could just tell her every time you were going to brush your teeth in the morning, you're going to take your antibiotics. When you brush your teeth at night, you're going to take your antibiotics. And for some of these patients, that's just like for her and mental health and everything, just so much easier. Otherwise, there's all this anxiety around, how do I take the third dose? When do I take it? And I think we have to be mindful of that. So that's what we actually changed hers to, her structure. And then it was really important that we stopped all her other products. Having a red complex with the yeast, we know that that is one of the highest resistant biofilms you can have. It's actually one of the hardest cases. That's why we were so excited, because I did not think we were going to get the results we did. I even set the patient up expectation wise that, hey, if we could get everything into green, if we could just get things yellow and green, we will be happy. But going in, we really had strong conversations that we need to stop the products that are just killing, because it's actually able to kill off all the healthy and allows these bad, more aggressive complex to go higher and higher. And when our bacterial balance gets out of balance, the yeast has the overgrowth. So that was one of our focuses with the patient, to really understand that. And then to stop her supplements that we had her on, because we had quite a bit and we didn't want it to be ineffective. We did start her on Supermouth. That's why I pulled this protocol up, and she did the kit. I always stress this extra spray. And people ask me why, because it has K2 and D3 in there, right? And we know she needs that. And I need that for bone health. I need that for tissue support. It has sodium bicarbonate. It has erythritol and xylitol. So what am I doing in that environment to create health and have good bacteria grow back? We've got to be giving the right pH and the right environment that the healthy can actually grow. If I'm using a biocide or antimicrobial, I'm killing off 99.9% of bacteria. I'm killing off the good that I'm actually trying to grow. So I know that's some brain pain for a few of us, but that's actually our core philosophy I'm sharing with you tonight, is that we're constantly looking at how do we create an environment for health, just like Dr. Gina does in the body. I've got to work on lifestyle. I've got to work on diet. I've got to work on these precursors. I got to work on my supplementation so that the body can actually create health. If she doesn't give the body B12, doesn't give the body K2 and D3, how do those cells get healthy? How do we actually create health in the body from a cellular level? And so we're taking these medical concepts and applying it to our care here. Now, for probiotics, it's pretty black and white, and these are where we'll take deep dives, but honestly, the research is there. We have a monopoly if you have red complex. Now, I'm not talking about lowering things. I'm talking about direct targets. I want to directly target TF, TD, PG. She has TF and TD. I need to choose the probiotic that has Oralis, Uberis, and Radis that targets red complex. And that is owned by Probiora. Now, if I didn't have the red complex, one, I wouldn't even be using an antibiotic. And two, I'd be choosing one of the other white labeled products that have Bliss or L-Reuteri that target orange zones. So that's for you, Dr. Isaac. He asked me, why are you picking Probiora? Because it's a target for red complex. If I don't have red complex, then right, the decision's made, and I can pick, we can name all those other products, you know, from Stella Life, BioGaia, Burst, ProDent. There's so many out there. I don't want to leave a bunch off, but we have a whole section on that. But just want you guys to be aware of that. So what is the protocol? Well, what if you don't have laser? What if you don't have airflow? You have ultrasonics. I know it's 2024. You all have a piezo or ultrasonic. So you're going to get those tips out. You're going to get the patient numb. You're going to turn it up high. You can all do a tongue prophy. You all have a prophy cup and the side of your ultrasonic. That's a tongue prophy. We need to clean that area off. And if you're really desperate, I don't care, scrape their tongue. Get a good tongue scraper and use that. We've got to clean that tongue off. And then go in there and do what you were trained to do. Do really good hand instrumentation. And then we're going to repeat like a cake, right? Layering, layer back out, at least go back in there with at least a thin cert. And now we're just hanging out in that epithelium, in the sulcuses, everywhere on this patient, because we know the fluid is moving. We know these travel, and right, we're going to back that direction. And I always do either Stella Life gels if there's a lot of bleeding, hemorrhaging, right, swollen, make them feel better. We know the gel has an anesthetic effect. Oh, and you could really do both. And there's times I have been both. But minimally, I put a varnish on, fluoride varnish, because I don't want them to have any sensitivity. So we really want to cover up those roots, cover up that enamel surface, just like this patient, right? She had new tooth surface that she hasn't seen in over 15 years. I kid you not. I'm sure that would be sensitive. And so, right, we want to make sure this is a positive experience. And that's part of this protocol as well. Now, we did home care, electric brush. I love the soft picks, right? Because I like to open that space up in between. Again, those can be all your favorite. And here we started with the GI probiotic. We end with it. So on day 15, we post-test and we get them back, rebuild that GI because we just tore it down. Now we got to rebuild both oral probiotic, create health, and the GI, because they're swallowing, we need health in that GI. That's going to be her immunity. And we're going to really focus that now with that cytomegalovirus. I put this one up here because if you don't have the opportunity to do a shake, your patients may be like, whoa, you're a dentist. Why are you telling me to do this GI shake? I'd like to always share, hey, one, we can simply look at Orthomolecular is a great brand. They have Orthobiotic 100. The other thing I'm going to tell you, every pharmacy carries Floristore, and we know S. boulardii, Saccharomyces boulardii, is actually a yeast. There is no antibiotic that we know of today in 2024 that actually touches Floristore. So that is, again, just a great thing that you could easily write out, tell a patient when they get their antibiotic to pick up a simple probiotic like that that's name brand, but there are lots of good ones too over the counter. Dr. Gina, anything you'd like to add to that about our therapy?
I don't think anything I would add about the therapy, but I would just like to point out that, again, getting her nutrient and micronutrient status optimized, also supporting the immune system in that direction. And again, the fact that somehow we never picked up on the fact that she went back to Skittles or whatever it was on a daily basis, even after the cruise. So it's where two teams can be much more powerful than either of us alone.
Laura, someone asked, they don't have any idea what super mouth is.
Well, that's so great because we're going to jump into the symposium. We had Dr. Cami Haas. He is orthodontically trained dentist, and he formulated the company Supermouth. Love to have anyone drop in the chat or raise your hand if you've used it or comment, but he really is trying to change the face of products. So what I love about is everything's EWG safe because he wants to make it safe for children, safe for adults. He's putting things in there that I said that really create health. He is moving away from the movement of like biocidal, like kill everything. If you're at the symposium, hopefully you got to meet our Let's Get Oral podcast. And one of the big things that, they talk about is how, right, we treat our mouth like our toilet bowl, and the fact that we're constantly dumping bleach and all these antimicrobials, like killing everything. And okay, that's great for our toilet bowl, but why are we doing that in our mouth? And so I think we are starting to see this big movement, and he's really leading that we have to put things in the mouth that actually create health, the environment for health to grow instead of killing things off. And there's tons of research on this. We had Dr. Nathan Bryan talk about that because this is also connected to nitric oxide. We know many of our products kill off so many of our healthy commensal bacteria. And we make nitric oxide two ways. So as much as I want to point to her that maybe she's an airway problem and not making nitric oxide. Her ADMA was a little high. That's because of nasal breathing. But now I have to wonder, and we're going to know on her next couple of blood work, I'm going to be able to see, hey, is she not making nitric oxide because she never had healthy oral bacteria? And so we make nitric oxide, the second pathway is through our mouth. Healthy bacteria like Neisseria, Rothia actually take the nitrate to nitrite to nitric oxide. And that's so important in our vascular system. So I know I'm not specifically speaking on Supermouth. I want you to look for these kinds of products like Supermouth. I would encourage all of you to learn. I believe there is an ambassador on here. Michelle, are you here?
Yes, I'm here.
What would you like to say about Supermouth since you are spokesperson?
Oh, I just that it is truly revolutionary. Just been able to switch a lot of my patients on it and seeing great test results just from using Supermouth. And so I do truly believe it's going to be the change that we need to see. And yeah.
Well,
Sorry.
perfect.
A question I have for Michelle and Laura, I'm not promoting Supermouth over any other, like we love Probiora. There are a lot of great brands, but someone did ask specifically, as you said, Dr. Wilkerson, about the Supermouth kit. So I put the website up there, the URL to go to supermouth.com. But Laura and Michelle, I want to clarify, we put together what we want them to have in the kit. Like, it's not a kit that's got the spray and the rinse and the toothpaste specifically that we're recommending, right? We're telling the patient, this is what you need to purchase separately from Supermouth for your kit. Is that right?
They can make their own kit. Those patients did have all the toothpaste, mouth rinse, and the spray. I love the spray, but I want to say it's really the ingredients, guys. I do, and that's what Dr. Jane, I think you're trying to say, is because we love xylitol. We love the sodium bicarbonate, right? We love the erythritol in there. And so we're looking for things to create health. And if you're going to go shop around products, right, look for those products, right, Rhoda? We've got xylitol products. And I'm going to say, even too, if this was an implant patient, so if I had a caries patient, like if I would have known going in, right, maybe I would have just done 100% xylitol with the spray, knowing that I wanted to create, because of the yeast, I needed some of that sodium bicarb, and I did want her in the K2 and D3. So again, I'm picking certain ingredients in these products because if this was an implant patient or somebody who needed a lot of healing, I will tell you, my next go-to is going to be Stella Life. And so you will see those three products, and I want to give like homage to those people that we really look for is, right, it's the ingredients in their products, right? We're creating health, and none of them are like considered antimicrobial. They actually have kill off, but they're actually creating health in the process. That's their main focus of these products. So great that you added that. What else?
I have a question.
Yes, Kelly.
Hi. So in the naturopathic world, I see on social media a lot of buzz around mold and parasites. So I've often wondered if, Dr. Pritchard, if that's something that you find of value to determine also with your patients, if that is something that could be affecting their health.
Yes, I do. It could be, definitely. And I almost never start there, but we do have patients that come in and say, I smell mold in my house, or because of whatever situation, I'm concerned about mold. We had a couple recently that went on a cruise and were like, we know there was mold in this certain part of the ship. It's never wrong to check for it because we find it a lot. And we like the Quicksilver Scientific kit for that. And there's one other, the name escapes me, a different brand as well, that's good. So not wrong to start with that. And then I do love the Cell Core detox products for parasites. We could do a whole show on parasites and mold, probably one each, if you will, but they are not left out of the conversation tonight because they're not very important. It's just we kind of start on these other things that are a little more common, not that it's right or wrong. I think it's great to start with mold or parasites. And sometimes we have complex cases, we have to refer to somebody to, like, we've done everything we know to do, because mold can be tricky, Lyme can be tricky, parasites can be tricky, but not to be ignored. You're right. Thanks for bringing that up. Do you treat that as well?
No, it's just something that I always wonder about. You kind of think like, I wonder, if this could be something that's contributing to some of the inflammation in their gum tissue. If it's something more systemic when you're trying to figure out the why.
And that's why I
Definitely.
love the viral load on there, because we're getting those herpes, that Epstein-Barr is on there. And I've already, helped a few people refer to physicians for that to get further testing. Like, why do they keep expressing? And a lot of it's coming back to our Epstein-Barr with mold and Lyme. And right, that's why some of these people can't fight these viral infections off. There's other
Mhm.
things that are going on. So that is just huge comment. Love it, love it, love it. And I don't know if we'll ever get rid of parasites, but at least we need to be talking about it, like in the
Yeah.
conversation, right? We have viral, fungal, yeast, right? We got parasites. We have a lot going on in this amazing human body, but trying to get things in balance. And I think that's kind of that conversation. Like, what is the root cause? Where can we start? What can we look for? And when some of these things aren't resolved, Kelly, then you're right. It's like, okay, so this just keeps pointing me in
Mhm.
another positive direction.
And then it also makes me wonder, some herbs that they talk about to, treat when there are parasites, do they have an effect on the red complex bacteria? Are they beneficial for patients to help clear some of that from their bloodstream as well? I don't know if that's anything that's been studied in relation to antibiotic effectiveness over herbs.
Actually, we're going to start talking about that. I want to do a whole antibiotic presentation, because that is, I'm going to say, a lot of controversy and wherever you stand on that. But the other thing is that we have to understand that medications are originally made from these herbs, and some of them are very like antibiotic or anti microbial, really, classification. And so they're not strong enough to kill everything off. And that can cause actually some bigger issues. So when we study the red complex, instead of getting rid of the red, they're doing what our other antimicrobials are doing. They're eliminating our lower level and can actually allow some of these stronger species to sustain. So if you use that, that's why, to me, again, it's just what we do in blood work and medicine. If I want to go that route, then that's why I need to keep testing and screening to see what's actually happening. How is the host responding? It would be like us putting her originally on a statin and then never testing her to see if it works, or increasing her B12 and never testing to see if it increased. And so that's really my big message there, is a lot of people are using these things and saying, oh, well, it's antibacterial or it's antimicrobial, it's natural. But we do need to realize that these are considered, believe it, really high classification of antimicrobials. And so again, we need to classify them, speak about them correctly. And that's like a whole, again, another series. But I'm glad you brought that up. They can be helpful at low levels. So I think that's my takeaway. Why testing is important. Because if you wanted to say to me, it's in green, Laura, you said you probably wouldn't use an antibiotic. Well, what do you think about this? Hey, yes, right? Let's look if this patient's a candidate versus like this patient who had such high levels. We're talking hundreds of thousands to millions of species in their bloodstream. It's has antibacterial and antimicrobial properties, but is it actually eliminating the complex we need? Or is it eliminating lower level because of the strength that it's at?
Thank you for that. I've always wondered, is that an alternative or something that can cause a bigger problem, or has it even been studied? So thank you for that.
There are. And so I want to say yes and yes. So test, test, test. And that's what's fun about it, is some of these green, that's why it's so important. Like, is there yeast? Is there a viral load that may help you make that decision? And how much is there? Right. If it's low level, I say go for it. That's what they were intended to do, right? Our body was never intended to be so high. And a lot of this is just, to our diet, like you said, all these other variables. And so those decisions, you know, can be helpful when we have other testing to look at, such as a saliva test, to know what concentration things are at. And I would say that's
Thank
like,
you.
I would tell Dr. Gina, you know, we had a patient, it's like, you know, we tell a patient, hey, we really want you to go on a stent. And they're like, well, I'm worried about my brain health. I really don't want to go on medication. I don't want to do this. I really don't want to go on it. And we say yes. And then all of a sudden they're having an event. Oh my God, I think I'm having a heart attack. And I was told Dr. Gina's like, right, we're racing down with them in the gurney. And they're like, okay, Lauren, now tell Dr. Gina to call me in the stand. It's kind of like, okay, well, that's too late. Now we need open heart surgery, or now we need a stent. And that's that red. I'm in the red high level. I have so much going on that now you just
Mhm.
want to give me like this thing that's supposed to help, something topical, and it's already so advanced. So I want us to really start thinking about that critically, because the more we can screen our patients with airway and catch it early before it is, right, sleep disordered breathing, can we catch those upper airway resistance and not have to go to a CPAP? Wow, can we catch these bacteria when they're just in the green, get them in the chair and use some of these great things you're talking about? I say yes. But most of us are waiting till I say our patient's on the gurney, you know, going in
Yeah.
for the
Yeah.
and they're like, okay, give me the statin and turn around. It's pretty hard to do. Yeah.
Yeah. Well, thank you for that. That's a great explanation.
Something interesting I saw in the news this week was a projection that by 2050, 62% of Americans will suffer from cardiovascular disease in a way that will require treatment. And so we're not talking about something that's obscure, or, you know, represents a very small percentage of the population, but actually a growing and growing and growing number. And we'd love to see dentistry on the front lines of this whole discussion. Another area where we're really trying to create a pressure point or a pain point of need to begin doing some of the things that what 1/2 of 1% of us are actually doing is in the subject of the thought that when you remove somebody's teeth, then all of a sudden bacteria aren't an issue anymore. And so you can remove their damaged, diseased teeth and gums, and we can immediately put implants in, and everything's going to be good. And so we don't need salivary testing for people that are going to have their teeth removed and implants put in. And yet we see implant failures and we see peri-implantitis. And where is all that coming from? So we're actually trying to research that in great detail to see if we can't create a whole new population of interested professionals who, like Dr. Yu on the call, who's does a lot of implants, right, Robert? That would be interested in knowing why implants sometimes fail, why we see bone loss around implants, and the relationship there with oral pathogens. And so maybe mention that for a second, Laura, before we start wrapping things up.
Sure. We do know that new testing is coming out on Pseudomonas, that it is in over 35% of implant failures. So not only peri-implantitis, but mucositis, that we see this, we see these high levels of PI and orange zones in implant failures. And so I always say, well, why is that? You know, we always have to ask why? How far can I go back? Why? And so I think we have to understand that just what you're saying, Dr. Wilkerson, is that when we just take out a tooth, where are these bacteria? And when we test these patients, we kind of have to have a global, at least understanding of the complexes. We know that the early colonizers are green colonizers. They're on the enamel, they're aerobic, they like oxygenation, they might be in a 1 millimeter or so. And then we move and grow and maturate into the orange. And these are completely tissue invasive. So now they're in that extracellular matrix. They're in 1 to 2, up to 3 milliliters, not just in depth, but also I want you to think like width, like internally, like going deeper into the epithelium lining. And then as we maturate further, we get into the red complex, and they're not only tissue, but many of these are completely bone and blood invasive. They can cross over any lining, and that's really because they are anaerobic and they want to get into that bloodstream, and they can then be in other areas of the body. And so looking at implants, if somebody lost a tooth because of having these bacterial species, they may have not even had signs or symptoms, or maybe they did. Maybe it was an abscessed tooth that we did a root canal, or the tooth fractured or reoccurrent, we couldn't save the tooth. If those species are there in the bone and in the blood supply, I say it's just coming back, right? We're just feeding those bad bacteria right around now that implant. No different if they lost their teeth to periodontal disease, right? They had those bacteria species, they're in the tissue, they're in the bone, and they're in that recirculating. Remember, 25% recirculates through our salivary glands from the blood. We make our saliva from the serum of the blood. So this is truly oral systemic. And with implants, I say it's just a matter of time. Peri-implantitis, to me, one of the biggest trends going on, right? We should start to awaken to that why the testing is so important before we drop that in. Are we dropping it truly in a healthy environment, or is there species just waiting, what I say, to attack that is just going to take some time? But the new Pseudomonas will be coming out on Simply Perio. They'll be releasing that, and that will be very helpful then to peri-implantitis and to these implant failures. But I also say to prior to placement, right, to prevent that, as you're talking about, Dr. Wilkerson. I think that's so important. I do want to open to just some our speakers that were on that did such a fabulous job at the symposium. If anybody has a question, I know some of my big highlights, I will say, I don't know if Dr. Hang is on here, but blown away by Dr. Hang, blown away by Dr. Alfie. If anyone wants to give me a heart or a raised hand that saw that, I just think that our whole concept of desaturation, thank you, Dr. Gomez. Yes, I mean, just really understanding how airway is connected to our systemic health. Just some of those takeaway with nitric oxide from Nathan Bryan. Just questions maybe any of you had about any of the speakers. I'd love to address those while we're on here. I'm going to show their faces. Maybe I'll stir up. Anyone have a question there? Do you see anything, Dr. Gina or Whit, that we could answer? So I just have to give a shout out to Dr. Hang for me, it was emotional because I've had some daggers in my back, and to hear his story of what I'm going to say perseverance for doing the right thing, right? Knowing, and Dr. Wilkerson, you could speak to that more eloquently, but his whole story at the end of sharing a family member and just how the trajectory of their life changed and changes, like we're talking about our patient today. It's very emotional that you can drastically have an impact on these patients' lives. And really, Dr. Alfie, Dr. Avis, they're all speaking that same message. So what would you add, maybe some of your takeaways, Dr. Gina, on that? I know you work closely with both of them.
Yeah, I totally agree with you. And I thought that it was interesting, Dr. Hang's perspective, that kind of like we were talking about with our first young patient on all of the psych meds, depressed and anxiety, and children and ADHD, et cetera. And his presentation talking about so many incarcerated, imprisoned individuals, just a missed airway issue. Not that that might not be the only thing going on, but there is a lot of people that just have a lot of mental health issues from a missed diagnosis, or maybe an incomplete diagnosis, or something that just totally wasn't on the radar, perhaps even from childhood. So I agree, it was very emotional. Yeah.
Dr. Hang is quite a unique individual. For you that don't know him, he has practiced orthodontics in Los Angeles for 40 years. And probably more than 30 years ago, he began to recognize that when he was extracting teeth and retracting arches to straighten out misalignments, that he was also causing changes in the volume of the airway. And so he began just following what he felt like was the logic of expanding versus retraction. and extraction. And he found that he was getting remarkable results, not only with the stability of the orthodontics and the comfort, but also with the overall well-being of his patients. And different disorders all of a sudden were disappearing, like sleep disorders and fatigue, things like that, that were hard to explain at first. He began to realize that what he was actually doing was increasing volume in a very positive way. So what happened after that was he was a very mainstream, well-known orthodontist and was a speaker. Well, he stopped becoming invited to speak in orthodontic circles because of his radical new thought processes that were basically unacceptable at the time. And it's taken 30 years for the profession to catch up to him, and still is in many ways. But at some point, being a little bit of a rebel with a cause, Dr. Hang decided to throw some things out to the public. So he created a syndrome, and his syndrome was called extraction, retraction, regret syndrome. And it was about people who had had 4 bicuspids removed and then their arches retracted, and now they were having problems, like feeling like they didn't have enough room for their tongue, feeling like they were clenching all the time, feeling like they were having trouble breathing and sleeping and fatigue, etc. And they just wanted out of that, what they felt like was an imprisonment. So he put that out on the internet and began getting phone calls and emails from all over the world from people saying, that is me, extraction, retraction, regret syndrome. Where do I go? And he was getting calls from people from all over, all 5, 6 continents. And so people began flying to Los Angeles to see him, and he's seen people from all over the world to treat them. And in fact, one of his popular treatments, which talking about radical, would be to reopen the spaces that were closed and put in 4 implants. And he's done many CBCT studies and sleep studies. I mean, hundreds and hundreds and hundreds, working closely with Stanford University and the research center there for sleep. And now, of course, things are coming around to the point where he's seen as a pioneer. And it wasn't like that for a long, long time. So though I would say his name is still controversial in some circles, he's certainly to be congratulated as someone who, tried to follow the logic and to care for his patients first, regardless of what others may say. And so we really do applaud him as a pioneer in some of the same areas that we're exploring together as a group. We need to wrap it up. And I thank you all. And Gina and Laura, thank you for leading the way tonight. But as we move forward with IDM Scholar Society, we want to sort of revisit our approach. And we realize that what people really are most interested in is how. We have spent a lot of time trying to share information on why, and a lot of details. We have online courses that go into 10, 12 hours on primarily why these things are true, what the research says, why it's important, what we're learning from others and each other. But we also realize that there's a lot of people out there that just want to know how. How do I do this? How do I treat that case that Laura and Gina were talking about? And so we want to really spread our wings more in that direction and to begin doing some things like some introductory, just 1-hour webinars with different groups around the country that are complimentary, introductory, behind the why, and then began to create some very attractive how courses that may be some shorter, some longer. At the symposium, we introduced something that we're working on, which is a sort of a mini residency that is all about how, where we'll talk about the things that Gina and Laura were talking about tonight, but make sure you understand every detail and then how to treat with those details. And so be on the lookout. We'll be in touch with you all constantly. And informing you on what's coming up next. But we're very excited about the future. We have some special contacts that have come up and different groups that have wanted to work with us, which will keep you all informed. And I would ask you, if you would, to invite your colleagues to join us in this study club, so that we can increase the dialogue with more and more people all over the United States. And then if you have a group that you feel like would be appropriate to learn more about what we're doing, please let us know and connect us, and we'll work out something to begin to help them as well. But until 2 months from now, when we have our next study club and other things that we'll be notifying you about, we hope that you have a great summer and enjoy your family and get away from home and spend some time leisurely, just relaxing and kind of de-stressing and enjoying life. So thank you, Laura and Gina and Kim, for tonight. And thank you all for being with us, and we'll be in touch. So
So you're not allowed to forget about us over the summer. We're going to be at the ADA coming up June 20. I'm going to put it out there.
oh,
Come
I didn't tell them about that.
Yeah,
Tell them, Laura, what we're doing in 2 weeks.
Yeah. So if you're looking for great information, you want to come hear more, learn more. We're always with such, I say again, just honored to be with talented speakers and making a difference. We will be at the ADA headquarters. Thanks to you, Dr. Whit Wilkerson, on June 21st and 22nd. Would invite your teams. Again, that's a 2-day kind of immersive. You can be hearing some of these thought leaders with others, just about oral systemic care and really making our patients healthier. And then we are going to be at Pankey. We're going to be probably at Dawson here. So be looking out for that as well. And we'll keep announcing those. Love to see you throughout the summer. So I'm not letting you guys go. You don't get off the hook. I'd love to hang with you this summer, because it's sometimes when I actually have the time, right? So I just want to say thank you. And we look forward to seeing everyone.
Yeah. Take care for now, everybody.
Thank
Bye.
you. Thank
Bye.
you.
Thank you.